So malnutrition, what is that? Well, I've defined it here as a disorder in body composition reflected in decreased body mass, decreased organ mass, and resultant decreased organ function. Now, malnutrition can occur for a variety of reasons. Protein-calorie malnutrition, obviously the most significant healthcare problem in the world, but you can have malnutrition from a specific nutrient deficiency or from altered metabolism resulting from a disease process, and it's that kind of malnutrition that we're going to be talking about today. Now, the incidence, even in American hospitals, is 25 to 50% on admission to the hospital and develops in an additional 25 to 30% of patients during their hospital stay. Morbidity is thought to be in the range of 25%, primarily wound and infectious complications, and mortality perhaps 5%, although obviously that can be difficult to quantify. To discuss this, I want to distinguish between the concepts of starvation and stress hypermetabolism. Now, starvation we're all familiar with. That's a clinical situation that develops whenever nutrient supply is inadequate to meet nutrient demand. It's characterized by a specific metabolic adaptive response that's aimed at preserving the lean body mass, developed over the eons so that when the crops didn't grow or the caribou herds moved or whatever, it was a way that we could get through that. The metabolic response is characterized by decreased energy expenditure, utilization of alternative fuel sources, and reduced protein wasting. Now, in the starved patient, the initial fuel sources are glycogen, which of course disappears within about 24 hours. And then glucose becomes the primary fuel source synthesized from amino acids via gluconeogenesis. In the fully adapted starved state that occurs 5 to 7 days after beginning fasting, fatty acids, ketones, and glycerol become the primary fuel sources in all but the obligate glucose-using tissues, that is, brain and red blood cells. In these patients, the respiratory quotient, that is the fraction of CO2 produced over oxygen consumed, is in the range of 0.6 to 0.7, reflecting utilization of fat as the primary fuel source. Also importantly is that these patients actually have decreased net protein catabolism and ureagenesis, at least compared to the fed state. Now, in stress hypermetabolism, this is a generalized response where energy and substrate are mobilized to support inflammation, immune function, and tissue repair. This occurs at the expense of the lean body mass. It occurs in response to a variety of stimuli. Now, I know I'm a surgeon, and so you think I'm referring just to trauma patients, but in fact, it occurs in response to burns, to pancreatitis, to sepsis, even to bone marrow transplantation. Now, this response, this stress hypermetabolic response, is usually associated with some degree of perfusion deficit, that is, shock, and the resultant microcirculatory injury, the influx of macrophages and lymphocytes to underperfused areas seem to be what kick off this metabolic response. Now, we talk about stress hypermetabolism, really talking about the metabolism that goes along with SIRS. We see increased oxygen consumption, and in order to support that, increased cardiac index, decreased systemic vascular resistance. We see increased minute ventilation. Laboratory-wise, we see hyperglycemia, an elevated lactate, and increased urinary nitrogen excretion. Now, the RQ in these patients, different from starvation, is in the range of 0.8 to 0.85, reflecting utilization of a mixed fuel source. In the stress patient, carbohydrate metabolism is characterized most prominently by hyperglycemia. Now, we've always referred to that as insulin resistance. But the other problem is increased gluconeogenesis that's poorly suppressed by glucose infusion. In other words, these patients make glucose despite being hyperglycemic. Now, interestingly, these patients also have increased glucose oxidation. And how does that occur if, in fact, insulin-mediated glucose uptake is decreased. Well, in fact, these patients have increased non-insulin-mediated glucose uptake, particularly into the liver and inflammatory cells. Now, an important point, become more important later, is that the maximum rate of glucose oxidation is about 5 milligrams per kilogram per minute. So what I'm trying to emphasize in this slide then, it's not just insulin resistance, but it's ongoing glucose synthesis. And in fact, these patients use more glucose as a fuel source than do normal people. Fat metabolism is characterized by increased oxidation of all chain lengths. One of the problems is that these patients develop decreased essential fatty acids in the plasma. Now, this is in part due to hyperinsulinemia, related to the hyperglycemia, that results in suppression of fat mobilization. Usually don't see ketonemia in these patients, and with progression to multiple organ failure, triglyceride clearance can become a problem. You'll get calls from the lab when you send morning labs saying that there's fat floating around in your blood samples. Protein metabolism is characterized both by increased protein synthesis, but also increased protein breakdown or catabolism that basically results in a net increase in protein catabolism. We see increased muscle release and decreased muscle uptake of amino acids. That results in a rapid decrease in the lean body mass. Interestingly, we also see decreased albumin and transferrin synthesis in the liver, and we see increased ureagenesis and urinary nitrogen losses. So where are all of these amino acids going? Well, some of them undergo extrahepatic oxidation. The branch chains, leucine, isoleucine, and valine, can be burned as an oxidative fuel source. Some of these amino acids are redistributed to the viscera, to the wounds, and to the white cell mass for wound healing, clonal expansion, antibody synthesis, etc. Some, particularly alanine, are used as gluconeogenic substrate. And finally, a lot of these amino acids go to the liver, where they're used for the hepatic synthesis of acute phase reactant proteins, things like fibrinogen, ceruloplasmin, alpha-1 antitrypsin, complement, etc. The point of all this is that the skeletal muscle really becomes the substrate for these processes of inflammation and tissue repair. This slide is kind of complicated, but it's just showing how all of this gets started, how all of this stress hypermetabolism is regulated. Now, it's controlled at the endocrine level, the paracrine, and even the autocrine level. Now, traditionally, we think of insulin, that's the primary anabolic and storage hormone. It's responsible not only for glucose uptake and metabolism, but for protein synthesis and lipogenesis. Cortisol, glucagon, and catecholamine, sometimes referred to as the insulin counter-regulatory hormones, are responsible for mobilization of these energy and substrate reserves. So they stimulate gluconeogenesis, which of course requires then protein catabolism to support that, glycogenolysis and lipolysis. The inflammatory hormones that I've shown there, whoops. The hormones that I've shown here, I've listed four that you're familiar with, but up to 300 different hormones and compounds have been associated with the inflammatory response. Tumor necrosis factor causes stress protein catabolism. It causes increased energy expenditure even in normal human volunteers. It inhibits lipoprotein lipase and thus prevents the storage of fat. Interleukin-1 stimulates the release of ACTH, which then creates a hormonal milieu that favors gluconeogenesis and protein breakdown. Interleukin-2 stimulates lipolysis, platelet activating factor gluconeogenesis. This takes us back to that association with shock and the influx of macrophages and lymphocytes into the areas of injured tissue. They then start to stimulate this metabolism. So just to summarize everything here, the important things are that when we compare starvation and hypermetabolism, is that energy expenditure is decreased in starvation, but actually increased in hypermetabolism. The respiratory quotient is low in starvation, reflecting utilization of fat as the primary fuel source, whereas it's higher in the hypermetabolic patients, suggesting the utilization of a mixed fuel source. One of the important things is that mediator activation, gluconeogenesis, proteolysis, protein synthesis, and ureagenesis are all very pronounced in the hypermetabolic patient and not so in the starved patient. Perhaps the most important part of the slide is the response to feeding. In a starved patient, if you feed the patient, the starvation response goes away. Unfortunately, it doesn't in the hypermetabolic patient. And why? Well, the hypermetabolic patient's metabolism not being driven by lack of calories, but rather by sepsis, by abscess, by broken bones, by burned skin. And so you have to treat the primary problem before the hypermetabolic response goes away. So what do we recommend for nutrition support? This is kind of an interesting area that keeps changing every few years. The sort of classic traditional recommendations for the nutrition support of hospitalized patients is that patients who are malnourished, patients in whom malnutrition is likely to occur, we see those all the time when they come into our ICU, and patients who've not eaten for 7 days. When should it be started? Well, it certainly should be started as soon as the need is recognized and the patient's hemodynamically stable, but always within 7 days. Now, these are traditional or classic recommendations for nutrition support. Now, some literature has come out over the past 15 years that suggests we should be doing something different. Vandenberg and others showed that accumulation of an energy deficit early in the ICU admission was associated with ARDS, renal failure, pressure ulcers, and the need for surgery. Merrick and Zaloga, in a meta-analysis of 15 studies, showed that early enteral nutrition was associated with significant reductions in infectious morbidity and hospital length of stay. As a result of those kinds of studies, the guidelines set forth by the Society of Critical Care Medicine and the American Society of Parenteral and Enteral Nutrition in 2009 suggested that in hemodynamically stable patients, enteral nutrition should be started within 48 hours of admission. Now, what about TPN? Where does that fit into all of this? This is a study that you're probably familiar with, published by Casera and others in the New England Journal. This was a randomized prospective trial of 4,600 patients. All received enteral nutrition as they could tolerate it. And then half of the group was supplemented with TPN beginning at 48 hours after admission. In the other half of the group, they didn't receive TPN to supplement enteral nutrition until 8 days after admission. What did they find out? Well, the late initiation group had significantly fewer infections, fewer patients intubated longer than 48 hours, reduction in the duration of renal replacement therapy, and lower costs. And further, the late initiation group was actually more likely to be discharged alive and without decreased functional status. So the point of this is, even though we want to start nutrition early, we don't want to start TPN early. And then even a more recent study than that, this was a study called the EDEN trial, published by the NIH ARDS network. This study randomized 1,000 patients with acute lung injury to receive trophic or full enteral feeds for the first 6 days after diagnosis. They received full enteral feeds after that. The point of all this is that full enteral feeds did not actually increase ventilator-free days or reduce 60-day mortality or infectious complications. Full feeds were associated with more GI complications, and basically the conclusion was that full enteral feeds are no better than trophic feeds, at least for the first 6 days of admission. So, what should we be doing? Well, I think probably the most current thoughts might be that we should initiate nutrition support early, within the first 48 hours of admission to the ICU. We should minimize parenteral nutrition support, at least during the first week. And finally, understand that full enteral feeds don't seem to confer any advantage over low-dose trophic feeds during the first 6 days of feeding. So what can we do and not do with nutrition support? Well, we can minimize starvation effects, of course. We can prevent specific nutrient deficiencies. We may be able, at least in pediatric patients, to modulate to some extent the metabolic processes or the hypermetabolism associated with disease. On the other hand, we can't abolish the ongoing protein breakdown and wasting of the lean body mass that's associated with catabolic illness. In other words, your patient is going to lose weight. They are going to lose protein. They're going to lose muscle mass. It's going to happen. Now, 30 years ago, people used sort of as the goal of nutritional therapy to try and maintain a patient's weight throughout a course of critical illness. And of course, we all know now that if you try to do that, your patient's going to be fat and fluid-filled when they get out of the ICU. These patients are going to lose weight. This is my first audience response question. The way I've done it is to we'll go through the question, and then hopefully the answers will be provided in subsequent slides. So in this case, a patient recovering from sepsis and acute lung injury, his admission weight was 75 kilos, is difficult to wean from the ventilator. Minute ventilation is 15 liters a minute. His respiratory quotient on indirect calorimetry is 1.15. He's receiving 3,000 calories per day, 80% from carbohydrate and 20% from lipid. The most appropriate nutritional modification is increase the proportion of fat to 50% of the calories, decrease the total calories to 2,250 calories per day, increase the calories to 4,000 calories per day, or substitute protein calories for part of the carbohydrate calories. Oh, okay. Sitting there looking the wrong way. Okay, well, we kind of have a varied response. As you can see, the actual correct thing to do is to decrease the calories to 2,250 calories per day, and we'll hopefully in the subsequent slides explain why. So what are the energy and substrate requirements in critical illness? Well, they can be estimated from a variety of formulae that are out there. There's something on the order of 200 formulae available to help you calculate the nutritional needs of specific kinds of patients. Probably the classic formula is the Harris-Benedict equation. And if you use the Harris-Benedict equation, that helps you calculate basal energy expenditure, and then you multiply that times the stress factor of 1.2 to 2. How do you choose who gets 1.2 to 2? Well, a 50% burn patient gets about 2 times their basal energy expenditure. Most of you just kind of walking around and sitting here in this course would get about 1.2 times your basal energy expenditure. Another way to do it is to use expired gas analysis, that is indirect calorimetry. If you do that, you don't need to add any stress factors because you are, in fact, measuring what the patient's consuming. Why do we worry about excess calories? Well, that can lead to hyperglycemia, to excess CO2 production and ventilator dependence, and to lipogenesis and hepatic steatosis. So generally, we recommend for most critically ill patients 25 to 30 kilocalories per kilo per day. For chemically paralyzed patients, and we did some work on this a number of years ago, they need about 20 kilocalories per kilo per day. And finally, the morbidly obese patient, that is with the BMI greater than 30, they need more on the order of 11 to 14 kilocalories per kilo per day. What about glucose? Well, as I mentioned earlier, there's a maximum rate of glucose oxidation, and that rate is 5 milligrams per kilogram per minute. That calculates out to about 7.2 grams per kilo per day. One of the important things to remember in these patients is that stress gluconeogenesis is going at a rate of 2 to 4 milligrams per kilogram per minute. What that means is that these stress patients may actually synthesize something on the order of 40 to 80% of the glucose that they're actually capable of oxidizing. Again, we worry about excess glucose because of hyperglycemia, excess CO2 production, hyperinsulinemia, and the suppression of lipolysis, and thus hepatic steatosis. So generally, we recommend 60 to 70% of the calories, or 20 kilocalories per kilo per day, or 5 grams per kilo per day as a place to start in terms of the amount of glucose that you should give. Fat. I mentioned earlier essential fatty acid deficiency. Well, in starvation, it takes 6 to 8 weeks for essential fatty acid deficiency to develop. All of us have enough fat on our bodies to avoid essential fatty acid deficiency for a couple of months. On the other hand, on the stress patient, essential fatty acid deficiency can develop as early as 10 days. Again, this hyperinsulinemia prevents the mobilization of fat. Fat calories can also minimize CO2 production. Excess fat causes hyperlipemia and hypoxemia. Generally, we recommend for the starved patient, which is not who we're talking about here, 2 to 5% of calories as fat. But the stress patient needs 15 to 40% of their calories as fat. Most of the enteral nutritional formulas that you might use have around 30% of their calories as fat. We do want to limit it to 1 gram per kilo per day to prevent those aforementioned complications. Protein. Well, as we mentioned earlier, protein catabolism is not suppressed by the provision of adequate calories or protein or amino acids in these patients. Therefore, the attainment of nitrogen balance then requires the support of stress protein synthesis, that is, inflammation, immune function, and tissue repair. In general, critically ill patients should receive 1.2 to 2 grams per kilo per day of protein. The RDA for protein, by the way, in healthy adults is 0.8 grams per kilo per day. So these critically ill patients that we're talking about here need 1.5 to 2.5 times the amount of protein that a normal adult requires. Obese patients tend to require more protein, 2 to 2.5 grams per kilo per day, and these are all from the joint guidelines published in 2009. One particular area is that the renal failure patient on CRRT, a lot of protein is lost via the CRRT circuit, and therefore these patients need up to 2.5 grams per kilo per day of protein. Electrolytes, vitamins, and trace elements. We don't really know all of the requirements in critical illness. We know that intracellular electrolytes, that is potassium, phosphorus, and magnesium, are required for the attainment of nitrogen balance. Vitamin and trace element requirements are not really known. So generally we recommend electrolytes to achieve normal levels, obviously considering excess losses, like in the patient that you're diuresing, or impaired excretion, the patient with renal failure, and with special attention to the intracellular ions. I'll come back to that later. Generally, we should provide the RDA for vitamins and trace elements. So this is another sort of summary slide if you're just looking at one thing before your board exam. Total calories, recommend 25 to 30 kilocalories per kilo per day. Glucose, about 60 to 70% of those calories, at least to start. Fat, 15 to 40% of those calories to start. Amino acids or protein, 1.2 to 2 grams per kilo per day. Again, patients on CRRT and morbidly obese patients may require more than that. Trace elements and vitamins provide the RDA. I put that little asterisk to remind myself that if you're using TPN, remember that the standard MVI preparation that goes into TPN doesn't have vitamin K in it. So remember to add vitamin K either to the TPN or weekly. And electrolyte levels, again, we try to maintain normal levels. What about the route of administration, enteral versus parenteral? I think people know that enteral is probably favored. In a meta-analysis by the Canadian Clinical Trials Group, this in 2004, they look at 13 trials, and determined that enteral nutrition was associated with a significant decrease in infectious complications. They found there were no difference in ventilator days, length of stay, or mortality. Bottom line is that TPN, causes more hyperglycemia simply because the glucose is delivered systemically rather than to the portal circulation. And enteral nutrition is cheaper. So the bottom line is that the indications for TPN are really pretty few. If the gut's available for use, you should use it. If it's not, or if you should use the gut, I mean. If the gut is not available for use, that is, the patient has short gut, the patient has bowel obstruction, or perhaps a proximal high-output enterocutaneous fistula, then TPN may be appropriate. Enteral nutrition is more physiologic, it's less expensive, it's associated with fewer metabolic complications. Enteral nutrition may reduce infectious complications compared to parenteral nutrition. The bottom line is use enteral nutrition whenever possible. What about types of enteral formulas? I just have some sort of general comments here, but first an audience response question. A previously healthy man suffers an abdominal gunshot wound that's complicated by peritonitis, acute lung injury, and acute renal failure requiring CVVHD. Early enteral nutrition is planned. Which of the following formula is most appropriate? A high-protein enteral formula, a renal failure formula, that is one that contains low protein, potassium, and phosphate, a standard enteral formula, or a formula containing fish oil and antioxidants. Okay, good. It looks like most people got that one. Maybe next year I can leave this part of the talk out. So enteral nutritional formulae are classified according, they can be classified a lot of different ways. One way is to classify them according to their clinical use. A standard formula, examples might be osmolite, are for starved patients who can't eat. High protein formulas, and there are a number of them, contain much higher protein, and they're designed for hypermetabolic patients. Now, just by way of numbers, a standard enteral formula has a non-protein calorie to nitrogen ratio of about 150 to 1, whereas a high protein formula may have a non-protein calorie to nitrogen ratio of 100 to 1 or even 80 to 1. Okay, the latter designed for hypermetabolic patients. There are calorie-dense formulas. They contain 1.5 to 2 kilocalories per milliliter. They're designed for fluid-restricted patients. You have to be careful in that some of them are relatively low in protein. And so either choose the right high-calorie formula, or if that's not one that's available to you, consider adding protein supplements if you're going to use one of these concentrated formulas. There are organ-specific formulas that are designed for patients with specific organ failures. I'll discuss those in a minute. And finally, there the group of formulae called immunity-enhancing formulas that were designed to alter immune function and reduce the inflammatory response. First, I wanted to mention organ-specific formulas. You're probably familiar with these, although we don't use them much anymore. Pulmonary failure formulas were designed for patients with acute on top of chronic respiratory failure. They contain 50% of their calories as fat for lower CO2 production. Probably more important just to avoid overfeeding, but occasionally you might use one of these formulas. Hepatic failure formulas, now these were designed by my old mentor, Frank Serra. They contained high branch chain and low aromatic and sulfur-containing amino acid compounds. Now, they will correct the amino acid profile, but unfortunately they don't seem to prevent hepatic encephalopathy. So these are really rarely, if ever, used anymore. Renal failure formulas, another kind of controversial area. They contain low protein, low potassium, and phosphorus. They're designed for patients with renal failure but not being dialyzed. The protein in these formulae is too low for stressed patients being dialyzed. So if you've got somebody on dialysis or on CVVH, they should not be receiving these renal failure formulas. I will say occasionally we have done it due to the low potassium and low phosphorus, but we also add supplemental protein to be sure and give the patient enough protein. At any rate, none of these are a proven benefit. The immunity-enhancing enteral formulas, I won't even go through some of these details, but they contain arginine, glutamine, and the omega-3 polyunsaturated fatty acids. This has been kind of an ongoing topic for nearly 30 years now. Darren Hyland and the Canadian Clinical Trials Group published this study clear back in 2001. This was a meta-analysis of the 22 randomized trials comparing enteral nutrition supplemented with some combination of arginine, glutamine, omega-3 fatty acids, and nucleotides to standard enteral formulas in terms of mortality and infectious complications. And they found that the immunonutrition type formulas did reduce infectious complications but didn't seem to reduce mortality. So at any rate, they became popular. More recently, this in 2008, Merrick and Zaloga analyzed a lot of the same trials, plus a couple of additional ones, but they did it in a little different way. They looked at diets containing arginine, glutamine, and fish oil alone or in combination. All of these diets contained antioxidants. Overall, they found that the immune-modulating diets reduced secondary infections, but didn't change mortality or length of stay. Now, they did show in 3 studies that diets containing fish oil alone significantly reduced mortality, infection, and length of stay. And you're probably familiar with those studies, one published by Gaddick and the next 2 by Pontes Arruda. Well, at any rate, as a result of all of those, the guidelines, again published by SCCM and Aspen in 2009, looked at several different things, and what their recommendations are these. Arginine might be beneficial in trauma and burn patients, but in severe sepsis patients it might actually be harmful. Arginine's a precursor to nitric oxide and may contribute to vasodilation and hypotension. The most important thing was that they recommended omega-3 fatty acids or fish oil as being beneficial in patients with acute lung injury and ARDS. So in 2009, this was the hottest thing. 2 years later, the following study came out, this by the NIH ARDS network. This was a randomized double-blind trial in patients with lung injury. And what they did was compare twice-daily supplementation of omega-3 fatty acids and gamma-linolenic acid, as well as antioxidants, to an isocaloric control diet. This stuff seemed to work, and the supplemented group had an 8-fold increase in plasma eicosapentaenoic acid levels. But unfortunately, they had fewer ventilator-free days, fewer ICU days, and fewer organ failure-free days. And in fact, the adjusted 60-day mortality was 25% in the supplemented group and 17% in the control group. So the point is, these immunity-enhancing diets are certainly not proven to be of benefit, and in acute lung injury, fish oil does not seem to be the thing to do. How do we assess nutrition? How do we monitor nutrition? Obviously, a history and physical is important. Anthropometric measurements, skin fold thickness and mid-arm circumference, those kinds of things, really have little utility in the ICU. Most of our patients are older, have different, they're edematous, they have different distributions of fat and muscle, so not really too useful in the ICU. Visceral protein levels, albumin, transferrin, retinol binding protein. The problem with those is that there are many non-nutritional influences that can affect them, and generally not too useful in the ICU. If you're going to use visceral proteins, transthyretin or thyroxine-binding prealbumin would be the other name, is probably the best one to use, but again, not really too good in critically ill patients. In critically ill patients, there is hepatic reprioritization of protein synthesis, and a sick liver doesn't make many of these regardless of the nutritional status. Electrolytes monitor daily, particularly potassium, magnesium, and phosphorus. Coagulation parameters weekly. What we do at our institution is measure weekly nitrogen balance and weekly indirect calorimetry. This is just a formula for nitrogen balance. I won't go through it, but it might be a good thing to review before a board exam. This is indirect calorimetry, and again, I apologize for the way some of these slides are overlapping. They really weren't on the original set that I made. I'm not going to go through a lot of detail, but what I want you to remember is kind of the extremes of indirect calorimetry numbers. A respiratory quotient in the range of 0.6 to 0.7 reflects utilization of fat as the primary fuel source, and of course the only people who use primarily fat as a fuel source are patients that are starved. On the other hand, if you have an RQ greater than 1, the only way that you get that, in other words, produce more CO2 than you consume oxygen, is if you're undergoing fat synthesis. People who are synthesizing fat are people who are overfed. So the point is, aim for an RQ somewhere in the middle, 0.8 to 0.95. Some of the complications of nutrition support, just hit them very briefly. Obviously, there are complications when you're talking about TPN related to central line placement, that is pneumothorax, vascular injury, arrhythmia. The key, of course, is using ultrasound guidance wherever possible to place lines, confirm line placement with chest x-ray, and use PICC lines. Infectious complications, the key to preventing them seems to be using a dedicated port, like in a triple lumen, using a dedicated port for TPN, standardized dressing change protocols, avoiding hyperglycemia, antibiotic-impregnated catheters, the little antibiotic-impregnated pads that are being put around catheters now. Many of those may help. The thing that I want to emphasize is that routine line changes, that is changing your lines every 2 days or 4 days or 5 days, are not effective in helping to reduce central line infection. What about complications of enteral nutrition? Well, we have a couple of different kinds of complications. We have complications related to access, that is tube misplacement, GI perforation, tube dislodgement, etc. And we have gastrointestinal complications. To prevent these complications related to access, be sure and confirm tube position with x-ray, place them with electromagnetic or fluoroscopic guidance, and then to prevent the removal and that sort of thing, use soft elastic tubes, be sure and secure tubes, use a lot of care in moving and turning patients. Gastrointestinal complications, these are always kind of vexing, and it seemed to be almost a trial and error sort of thing. To prevent vomiting, consider prokinetic agents, small bowel feeding. Sometimes in the patient having diarrhea, a change in formula can be helpful. You should avoid anti-anaerobic antibiotics for this and other reasons, of course. You should diagnose and treat infectious sources, and if none of that works, then try anti-motility agents such as Imodium or Lomotil. And finally, if none of that works, occasionally we do have to go to TPN. Hepatobiliary complications. There are a couple of different kinds. Hepatic steatosis, or fatty infiltration of the liver. This usually occurs early in the hospital course. It's characterized by elevated aminotransferases, and this is usually thought to be due to excess glucose and hyperinsulinemia. By the way, there's an extensive literature on this subject and a lot of things that are probably involved. I'm not telling you a comprehensive list of things to think about, but rather the simple ones that we clinicians do think about. At any rate, it's due to excess glucose and to hyperinsulinemia. The other type of hepatobiliary complication you see is intra and extrahepatic cholestasis. This tends to occur later. It's characterized by elevated canalicular enzymes and bilirubin. Patients get gallbladder sludge and stones. It's due to a lack of enteral nutrition. So the prevention and treatment of these problems then really is avoid overfeeding, avoid excess glucose, and feed enterally wherever possible, and you won't tend to have these hepatobiliary complications. My last audience response question. An elderly man presents with a small bowel obstruction. After 3 days of expectant management, he's operated upon for lysis of adhesions. On postoperative day 7, bowel function has still not returned, and he started on TPN. On post-op day 8, he's at risk for all of the following complications except cardiac arrhythmia, hemolysis, rhabdomyolysis, and metastatic calcification. Okay, very good. Most people got that one, metastatic calcification. I'm going to explain that a little bit. The intracellular electrolytes, potassium, phosphorus, and magnesium, as I mentioned earlier, they're required for the repletion of protoplasm and the retention of other nutrients. Feeding, particularly glucose, leads to rapid uptake of these intracellular electrolytes into the cells with resultant depletion of serum levels. This, of course, was first described with the liberation of Nazi concentration camps at the end of World War II, when starved patients were given chocolate, were given C rations, whatever, and several of them winged over and died. And this was due to the refeeding syndrome, the acute depletion of phosphorus, and then more recently we've added potassium and magnesium. Just kind of a quick summary, potassium, when it gets very low, obviously causes cardiac arrhythmias. Magnesium can cause cardiac arrhythmias. Phosphate, when it's very low, can cause hemolysis, white blood cell dysfunction, rhabdomyolysis, and cardiomyopathy. Very important to follow up on these electrolytes, more so than on the day that you start enteral nutrition. Follow it up the day after you start enteral nutrition. That's when I've seen levels drop precipitously low. People who had previously normal levels all of a sudden have a potassium of 2, a magnesium of 1.2, a phosphorus down around 1. Those are potentially lethal levels, so pay close attention. Excuse me. Last thing I wanted to mention was aspiration pneumonia. One of the questions is, where should you feed people? What about gastric feeding versus small bowel feeding? This another meta-analysis by the Canadian Clinical Trials Group. They found that small bowel feeding was associated with increased protein and calorie delivery and shorter time to target nutrient delivery. They also found that small bowel feeding was associated with a reduction in pneumonia. And then finally, in kind of a classic study, but I like to keep including it, a study by Drakulovic published in Lancet, clear back 1999. This study looked at 86 mechanically ventilated patients that were randomized to either the semi-recumbent or the supine body position. They found that pneumonia occurred in 5% of the semi-recumbent patients and 23% of the supine patients. They also found that the incidence of pneumonia was 50% when patients were both supine and enterally fed. So, bottom line here, elevate the head of the bed. So that's the end of my talk. In summary, the key points then are that one of the key points is it's important to distinguish stress from starvation metabolism. That's critical to providing appropriate nutrition support in the ICU. Remember, the critically ill patients may require more energy but are less able to tolerate glucose and require fat to meet their energy requirements. Remember that critically ill patients require more protein in order to achieve nitrogen balance, promote wound healing, etc. Remember that enteral nutrition is preferred. It's cheaper. It should be given early. TPN is acceptable, particularly if it's not given early and if the glucose levels are controlled. And finally, it's important to monitor nutrition in order that nutrition goals are met and that we minimize complications.